Welcome to The Explainer. Today, we're tackling a big one. It's a condition that leads to millions of doctors' visits and hospital stays every single year. We're talking about cellulitis. Okay, so picture this. A patient walks in and they show you their leg. It's red, it's swollen, it's warm to the touch, and it's really painful. And they tell you it just popped up out of nowhere and seems to be spreading fast. This right here, this is the classic picture we need to get a handle on. So, what you're looking at is cellulitis, and it's an infection that goes way deeper than just the surface. That's why in this explainer, we're going to build a really solid foundation for you to understand it, spot it, and know exactly how to manage it. So here's our game plan. We'll start with the basics. What is it? Then we'll dig into what causes it and who's at risk. After that, we'll get into the fun part, the clinical detective work. We'll even look at some tricky imposters that can fool you. And finally, we'll wrap it all up with how to put together a solid treatment plan. All right, let's jump right in. First things first, what exactly is cellulitis? Let's get a clear definition. Right, so the key thing to get is that this is not just some superficial rash. We're talking about an infection that has managed to get down into the deep layers of the skin, the dermis, and even into the subcutaneous fat right below it. And this diagram, it's perfect. It's like a map of the different battlegrounds in the skin. See up top? That's erysipelas, a more superficial infection. But cellulitis, our focus today, is happening deeper down, in the dermis and the fat. And then way down deep, that's where the really scary stuff like necrotizing fasciitis lives. So knowing where the infection is happening is absolutely crucial. So how does this all start? Well, just think of your skin as a fortress wall. It's usually pretty good at keeping invaders out, but all it takes is one tiny crack in that wall. A little cut, a bug bite, maybe some dry, cracked skin from athlete's foot, that's the invitation. Bacteria on your skin, which are normally harmless, see that opening, they sneak in, and they start to multiply deep inside. And that redness and swelling we see, that's basically the body sounding the alarm and sending in the troops to fight. Okay, so quick recap on this section. The big takeaway is that cellulitis doesn't just happen out of the blue. It's a deep infection, and it almost always needs some kind of break in the skin for the bacteria to get their foot in the door. All right, so we know what it is. Now let's get into the why and the who. What are the actual germs causing this, and who are the people most likely to get it? Okay, this is a huge clinical pearl right here. The first question you ask yourself is there pus? It's a fork in the road. If you're seeing just that classic red spreading rash with no pus, you should be thinking strep. But the moment you see pus or an abscess, your brain has to switch gears. Now you're thinking staph, and you've got to consider its tougher cousin, MRSA. And, this doesn't just happen to anyone. Some people are just more set up for it. Anything that weakens that skin fortress or messes with circulation is a risk factor. Think about chronic swelling in the legs, like from lymphedema or bad veins. That fluid-logged tissue is like a perfect petri dish for bacteria. And here's a really important one. If you've had cellulitis once, your risk of getting it again goes way, way up. So, wrapping up this section, knowing the bugs and the risks isn't just trivia, it's practical. It helps us zero in on the likely cause and starts shaping our plan of attack before we even get to treatment. Okay, so how do we actually diagnose this thing? Here's the deal. Cellulitis is a clinical diagnosis. That means you're not going to find the answer in a lab report or on an x-ray. The answer is right there in front of you, in the patient's story and what you find when you examine them. You've probably heard of these before, the 4 cardinal signs of inflammation: redness, warmth, swelling, and pain. This is the classic signature of cellulitis. The redness and warmth, that's just increased blood flow rushing to the scene. The swelling? Leaky blood vessels. And the pain? Well, inflammation hurts. If you see all 4 of these together, cellulitis needs to be number 1 on your list of possibilities. Now, this is a fantastic comparison and something you really have to look for. Pay close attention to the border of the red area. With cellulitis, it's kind of fuzzy, right? It just sort of fades into the normal skin. But with erysipelas, it's totally different. The border is sharp, it's raised, it's like a well-defined map. That's a huge clue that tells you the infection is more superficial. So let's just hammer this point home. When it comes to cellulitis, your most important tools aren't in the lab. They're your own 2 eyes and your hands. The history and the physical exam are what will give you the answer 9 times out of 10. All right, now we get to the really tricky part. This is where you have to put on your detective hat because a whole bunch of other things can masquerade as cellulitis. And I mean, some of them are no big deal, but some are incredibly dangerous. Let's be very clear about this. The one mimic you cannot, under any circumstances, afford to miss is necrotizing fasciitis. And the number one giant flashing red light is pain out of proportion. What does that mean? It means the leg might look a little red, but the patient is screaming in agony. If you see that, you have to think, this could be a flesh-eating infection, and it's a surgical emergency, period. And look, this isn't just a theoretical problem. This is real. A big study found that almost a third, 30% of patients admitted to the hospital for cellulitis didn't actually have it. They were misdiagnosed. Often it was something like Stacey's dermatitis from bad veins or even a gout attack. And that means a lot of people are getting unnecessary antibiotics and hospital stays. So to wrap up this section, that high misdiagnosis rate isn't about blaming anyone. It's about recognizing just how challenging this diagnosis can be. And that's exactly why learning to spot those subtle clues and consider the mimics is so important for taking good care of patients. Okay, we've talked about what it is, who gets it, and how to diagnose it. Now, for the final piece of the puzzle, what do we do about it? Let's put together a treatment plan. Look, we can break down the treatment decisions into a really simple, logical flow. Just ask yourself a few key questions. Step 1, how sick is the patient overall? Do they have a fever, low blood pressure? Step 2, is there pus? Answering those 2 questions basically tells you if they can go home on pills or if they need to be in the hospital on IVs. And it points you to the right antibiotic. And this table just lays it all out, right? It follows that logic we just talked about. No pus, and the patient looks well. You're targeting strep. So something simple like oral cephalexin is a great choice. But if the patient is sick, or if you see pus, now you have to worry about MRSA, and you're reaching for the bigger guns like IV vancomycin. And hey, don't forget the simple stuff that really works. Elevating the leg makes a huge difference with the swelling. And for most straightforward cases, you only need about 5 days of antibiotics. But this brings us to our final big idea. Thinking about that 30% misdiagnosis rate, what does that tell us? It tells us that the real art of managing cellulitis isn't just about picking an antibiotic from a chart. The real skill, the thing that truly helps patients, is getting the diagnosis right from the very beginning.